Q&A student flashcards. These flashcards are based on the uploaded chapter. They focus on definitions, assessment findings, diagnostic tests, treatment, nursing care, complications, and high-yield exam concepts. Section 1. Menstrual Cycle Basics. Card 1Q. What hormones control the menstrual cycle? A. GnRH from the hypothalamus stimulates FSH and LH from the pituitary. FSH and LH stimulate the ovaries to produce estrogen and progesterone. Card 2Q. What happens to the endometrium during the menstrual cycle? A. It proliferates in response to ovarian hormones and later sheds during menstruation. Card 3Q. What is the average menstrual cycle length described in the chapter? A. About 28 days, with a typical range of 26 to 34 days. Card 4Q. When are menstrual cycles most irregular? A. During the first 2 years after menarche and during the approximately 5 years before menopause. Card 5Q. Can long intervals between periods be normal during early adolescence? A. Yes. During the first 2 years after menarche, intervals of 3 to 6 months between menses can occur. Section 2. Amenorrhea. Card 6Q. What is amenorrhea? A. Absence of menstrual flow. It is a clinical sign rather than a disease itself. Card 7Q. When should absence of menarche and secondary sexual characteristics be evaluated? A. By age 13. Card 8Q. When is absence of menstruation considered primary amenorrhea? A. When menses have not occurred by age 15, regardless of normal growth and development. Card 9Q. When is secondary amenorrhea identified? A. When menstruation stops for 6 months or longer after menstruation had previously occurred. Card 10Q. What is the first condition that should be ruled out when evaluating amenorrhea? A. Pregnancy. A beta-HCG pregnancy test is an important initial step. Card 11Q. What are common causes of amenorrhea? A. Pregnancy, outflow tract obstruction, pituitary disorders, PCOS, thyroid disease, type 1 diabetes, medications such as phenytoin, substance use, and oral contraceptive use. Card 12Q. What is hypogonadotropic amenorrhea? A. Amenorrhea caused by a problem involving the central hypothalamic pituitary axis. Card 13Q. What can suppress the hypothalamic pituitary axis and cause amenorrhea? A. Severe stress, rapid weight loss, eating disorders, strenuous exercise, and mental illness. Card 14Q. What is the female athlete triad? A. The association of disordered eating, amenorrhea, and premature osteoporosis. Card 15Q. Why is amenorrhea associated with vigorous athletic training concerning? A. It can be associated with low bone density and osteoporosis, increasing the risk of stress fractures. Card 16Q. What tests may be used when evaluating amenorrhea after pregnancy is excluded? A. CBC, urinalysis, serum chemistries, FSH, TSH, prolactin, imaging of the sella turcica, a progestational challenge, and pelvic sonography. Card 17Q. What is an important nursing intervention for hypothalamic amenorrhea? A. Address the underlying stressor, nutritional problems, excessive exercise, medication effects, and emotional distress. Section 3. Dysmenorrhea. Card 18Q. What is dysmenorrhea? A. Pain occurring during or shortly before menstruation. Card 19Q. What causes primary dysmenorrhea? A. Excessive prostaglandin F2 alpha causes stronger uterine contractions and uterine arteriolar vasospasm, producing ischemic menstrual pain. Card 20Q. Is primary dysmenorrhea associated with ovulation? A. Yes. It occurs with ovulatory cycles. Card 21Q. When does primary dysmenorrhea usually begin? A. About 6 to 12 months after menarche, when ovulation becomes established. Card 22Q. How long does primary dysmenorrhea usually last? A. Approximately 12 to 72 hours. Card 23Q. What systemic symptoms can occur with primary dysmenorrhea? A. Backache, weakness, sweating, nausea, vomiting, diarrhea, dizziness, syncope, headache, and poor concentration. Card 24Q. What is the difference between primary and secondary dysmenorrhea? A. Primary dysmenorrhea occurs with ovulatory cycles and has no pelvic pathology identified. Secondary dysmenorrhea develops later and is associated with pelvic pathology. Card 25Q. What conditions can cause secondary dysmenorrhea? A. Adenomyosis, endometriosis, PID, endometrial polyps, and uterine fibroids. Card 26Q. What type of pain is commonly associated with secondary dysmenorrhea? A. Dull lower abdominal aching that may radiate to the back or thighs. Bloating and pelvic fullness may also occur. Card 27Q. What diagnostic tests may help identify the cause of secondary dysmenorrhea? A. Pelvic examination, ultrasound, D&C, endometrial biopsy, and laparoscopy. Card 28Q. Why does heat help with dysmenorrhea? A. Heat promotes vasodilation and muscle relaxation, reducing uterine ischemia and cramping. Card 29Q. Which medications are commonly used for primary dysmenorrhea? A. NSAIDs, because they inhibit prostaglandin synthesis. Card 30Q. When are NSAIDs most effective for primary dysmenorrhea? A. When started several days before menstruation or at least by the onset of bleeding. Card 31Q. What important adverse effect should women taking NSAIDs report? A. Dark-colored stools, which may indicate gastrointestinal bleeding. Card 32Q. What should nurses teach about taking NSAIDs? A. Take them with food to reduce gastrointestinal problems. Women with aspirin allergy or sensitivity should avoid NSAIDs. Section 4. PMS and PMDD. Card 33Q. What is premenstrual syndrome? A. A group of physical, behavioral, and emotional symptoms that begin during the luteal phase and improve after menstruation begins. Card 34Q. What are common physical symptoms of PMS? A. Breast tenderness, bloating, edema, weight gain, headache, fatigue, and backache. Card 35Q. What are common emotional symptoms of PMS? A. Irritability, anxiety, depression, crying spells, panic attacks, and difficulty concentrating. Card 36Q. Why does PMS require ovarian function? A. PMS does not occur when ovarian function is absent. Card 37Q. What is PMDD? A. A more severe form of PMS characterized particularly by marked mood and affective symptoms. Card 38Q. How many symptoms are required for PMDD according to the chapter? A. 5 or more effective and physical symptoms must occur in the week before menses and improve during the follicular phase. Card 39Q. What must be present among the PMDD symptoms? A. At least one must involve marked affective lability, irritability or anger, depressed mood or hopelessness, or anxiety. Card 40Q. How is PMDD confirmed? A. Symptoms must be documented through prospective daily ratings for at least 2 menstrual cycles. Card 41Q. What lifestyle interventions may help PMS? A. Regular exercise, dietary changes, reduced salt, sugar, and caffeine, stress reduction, and symptom tracking. Card 42Q. Which medications are first-line pharmacologic therapy for PMS according to the chapter? A. SSRIs such as fluoxetine, sertraline, citalopram, escitalopram, and paroxetine. Section 5. Endometriosis. Card 43Q. What is endometriosis? A. Growth of endometrial tissue outside the uterus. Card 44Q. What happens to ectopic endometrial tissue during menstruation? A. It responds to hormonal stimulation and bleeds, producing inflammation, fibrosis, and adhesions. Card 45Q. What is a chocolate cyst? A. An ovarian endometriosis cyst containing old blood that gives the cyst a dark appearance. Card 46Q. What theory explains one possible cause of endometriosis? A. Retrograde menstruation, in which endometrial tissue refluxes through the uterine tubes into the peritoneal cavity. Card 47Q. What are the major symptoms of endometriosis? A. Pelvic pain, dysmenorrhea, and dyspareunia. Card 48Q. Can the severity of pain predict the severity of endometriosis? A. No. The extent of pain does not necessarily correlate with disease severity. Card 49Q. How can endometriosis cause infertility? A. Adhesions can distort the uterus or block the uterine tubes, interfering with movement of the ovum. Card 50Q. What is a major goal of medical treatment for endometriosis? A. Suppress endogenous estrogen production to reduce growth and symptoms of endometrial lesions. Card 51Q. Which medications suppress ovarian function in endometriosis? A. GnRH agonists such as leuprolide, nafarelin, and goserelin. Card 52Q. What important adverse effects occur with GnRH agonists? A. Menopausal symptoms such as hot flashes and vaginal dryness, along with bone loss. Card 53Q. Why is treatment with GnRH agonists generally limited? A. To reduce the risk of bone loss. The chapter describes treatment as usually limited to about 6 months. Card 54Q. What is a major adverse effect of danazol? A. Androgenic or masculinizing effects such as weight gain, oily skin, hirsutism, decreased breast size, and deepening of the voice. Card 55Q. What is the definitive surgical treatment for endometriosis when fertility does not need to be preserved? A. Total abdominal hysterectomy with bilateral salpinectomy and oophorectomy. Section 6. Abnormal menstrual bleeding. Card 56Q. What is oligomenorrhea? A. Infrequent menstrual periods, generally with intervals of 40 to 45 days or longer. Card 57Q. What is hypomenorrhea? A. Scanty menstrual bleeding occurring at normal menstrual intervals. Card 58Q. What is metrorrhagia? A. Bleeding occurring between normal menstrual periods. Card 59Q. What is breakthrough bleeding? A. Small amounts of bleeding that occur when the endometrium sheds despite hormonal contraceptive use. Card 60Q. When is breakthrough bleeding most common with OCPs? A. During the first 3 cycles. Card 61Q. What is menorrhagia? A. Excessive menstrual bleeding in either duration or amount. Card 62Q. What laboratory values help determine the effect of heavy menstrual bleeding? A. Hemoglobin and hematocrit. Card 63Q. What should be considered when a woman has a single episode of unusually heavy bleeding with pelvic pain? A. Early pregnancy loss should be considered. Card 64Q. What test should be performed when early pregnancy loss is suspected? A. Hematocrit and serum beta-HCG. Card 65Q. What is abnormal uterine bleeding? A. Uterine bleeding that is irregular in amount, duration, or timing, and is unrelated to regular menstrual bleeding. Card 66Q. What is a common mechanism causing abnormal uterine bleeding? A. Anovulation, which can result in inadequate progesterone support of the endometrium and subsequent shedding. Card 67Q. What conditions can cause abnormal uterine bleeding? A. Pregnancy complications, infections, adenomyosis, fibroids, polyps, endometrial hyperplasia, cancers, endocrine disorders, anticoagulants, hormonal medications, and other medications. Card 68Q. What is a common benign cause of heavy menstrual bleeding? A. Uterine leiomyomas, also called fibroids. Card 69Q. What surgical procedure preserves fertility in a woman with symptomatic fibroids? A. Myomectomy, removal of the fibroids while preserving the uterus. Card 70Q. What procedures may be used when fertility does not need to be preserved and fibroid symptoms are severe? A. Uterine artery embolization or hysterectomy. Section 7. STI prevention. Card 71Q. What is the most effective strategy for reducing STI complications? A. Primary prevention through behaviors that reduce infection risk. Card 72Q. What are the 5 petaseconds used in STI assessment? A. Partners, practices, protection from STIs, past history of STIs, and pregnancy intention. Card 73Q. What barrier method is emphasized for STI prevention? A. Latex male condoms used consistently with every sexual encounter when STI transmission is possible. Card 74Q. Do hormonal contraceptives protect against STIs? A. No. Women using hormonal contraception or IUDs may still need condoms for STI protection. Card 75Q. Does douching reduce STI risk? A. No. The chapter associates douching with increased risk of PID and ectopic pregnancy. Card 76Q. Which vaccines can prevent some STIs? A. Hepatitis B and HPV vaccines are identified in the chapter. Section 8. Chlamydia. Card 77Q. What is a major problem with chlamydia in women? A. It is frequently asymptomatic and can cause serious reproductive complications. Card 78Q. What is a major complication of untreated chlamydia? A. PID, which can lead to ectopic pregnancy and tubal factor infertility. Card 79Q. What symptoms may occur with chlamydia? A. Spotting, postcoital bleeding, mucoid or purulent cervical discharge, and dysuria. Card 80Q. What test is highly sensitive for diagnosing chlamydia? A. Nucleic acid amplification testing, or NAAT. Card 81Q. What medications are identified in the chapter for chlamydia treatment? A. Doxycycline or azithromycin. Section 9. Gonorrhea. Card 82Q. What organism causes gonorrhea? A. Neisseria gonorrhoeae, a gram-negative diplococcus. Card 83Q. What symptoms may occur with gonorrhea in women? A. Greenish-yellow purulent cervical discharge, pelvic pain, menstrual irregularities, dysuria, and prolonged or painful menses. Card 84Q. What test is used to diagnose gonorrhea? A. Culture, including Thayer-Martin culture as described in the chapter. Card 85Q. What medication is identified as the treatment of choice for uncomplicated gonorrhea? A. Ceftriaxone administered intramuscularly. Card 86Q. Why should a woman with gonorrhea also be evaluated for chlamydia? A. Co-infection is common. Section 10. Syphilis. Card 87Q. What organism causes syphilis? A. Treponema pallidum. Card 88Q. What is the classic lesion of primary syphilis? A painless chancre. Card 89Q. What are major findings of secondary syphilis? A widespread maculopapular rash involving the palms and soles, generalized lymphadenopathy, fever, headache, malaise, and possibly condylomata lata. Card 90Q. Which tests screen for syphilis? A. Non-treponemal tests such as VDRL and RPR. Card 91Q. What tests confirm syphilis after a positive screening test? A. Treponemal tests. Card 92Q. What is the preferred treatment for syphilis, including during pregnancy? A. Penicillin G. Card 93Q. What is the Jarisch-Herxheimer reaction? A. An acute febrile reaction that can occur within the first 24 hours after syphilis treatment, with headache, muscle aches, and joint pain. Card 94Q. What should a pregnant woman know about a Jarisch-Herxheimer reaction? A. If it occurs during the second half of pregnancy, it can increase the risk for preterm labor and birth. Section 11. PID. Card 95Q. What is pelvic inflammatory disease? A. An ascending infection involving the upper reproductive tract, commonly including the uterine tubes and uterus. Card 96Q. Which organisms commonly cause PID? A. Neisseria gonorrhoeae and Chlamydia trachomatis, along with other aerobic and anaerobic bacteria. Card 97Q. What are the 3 minimum clinical criteria supporting treatment for PID? A. Lower abdominal tenderness, bilateral adnexal tenderness, and cervical motion tenderness. Card 98Q. What are possible complications of PID? A. Infertility, ectopic pregnancy, chronic pelvic pain, dyspareunia, pyosalpinx, tubo-ovarian abscess, and pelvic adhesions. Card 99Q. How much does one episode of PID increase ectopic pregnancy risk according to the chapter? A. The chapter states that the risk increases 7-fold. Card 100Q. What nursing position is recommended for acute PID? A. Semi-Fowler's position with bed rest. Card 101Q. What should the patient with PID be taught about sexual activity? A. Refrain from sexual intercourse until treatment is completed. Section 12. HPV. Card 102Q. What is HPV? A. A viral STI associated with genital warts and several cancers, including cervical cancer. Card 103Q. Which HPV types are highly oncogenic? A. HPV types 16 and 18 are identified as high-risk types in the chapter. Card 104Q. What is the appearance of typical genital HPV lesions? A. Soft papillary growths that may occur singly or in clusters and may become cauliflower-like. Card 105Q. Does treatment for genital warts eradicate HPV? A. No. Treatment removes the warts and relieves symptoms, but does not eradicate the virus. Card 106Q. What HPV treatments should not be used during pregnancy according to the chapter? A. Imiquimod, podophyllin, podophylox, and sinacatechins. Card 107Q. What procedure can definitively diagnose HPV? A. Histologic evaluation of a biopsy specimen. Card 108Q. What vaccine is used to prevent HPV infection? A. Gardasil 9. Section 13. Genital herpes. Card 109Q. What is the major characteristic of genital herpes? A. It is a chronic, recurrent viral infection for which there is no known cure. Card 110Q. What are typical findings during a primary genital herpes infection? A. Multiple painful lesions, fever, chills, malaise, severe dysuria, and tender ulcers. Card 111Q. How do recurrent herpes lesions differ from primary lesions? A. Recurrent lesions are usually less severe, unilateral, and shorter in duration, often lasting about 5 to 7 days. Card 112Q. What test can confirm genital herpes? A. Viral culture obtained by swabbing exudate during the vesicular stage. Card 113Q. Which antiviral medications are used for genital herpes? A. Acyclovir, famciclovir, and valacyclovir. Card 114Q. When should a woman with genital herpes avoid sexual contact? A. From the onset of prodromal symptoms until lesions have completely healed. Card 115Q. What should happen during labor if visible genital herpes lesions are present? A. Cesarean birth is recommended according to the chapter's guidance to reduce neonatal HSV exposure. Section 14. Vaginal infections. Card 116Q. What are the 3 most common vaginal infections discussed in the chapter? A. Bacterial vaginosis, candidiasis, and trichomoniasis. Card 117Q. What findings strongly suggests bacterial vaginosis? A. Thin white, gray, or milky discharge with a fishy odor and clue cells. Card 118Q. What vaginal pH is associated with bacterial vaginosis? A. A pH of 4.5 or greater. Card 119Q. What is the classic discharge associated with candidiasis? A. Thick, white, lumpy, cottage cheese-like discharge. Card 120Q. What vaginal pH is expected with candidiasis? A. Less than 4.5. Card 121Q. What finding appears on KOH preparation with candidiasis? A. Hyphae and pseudohyphae. Card 122Q. What is the classic discharge of trichomoniasis? A. Yellow-green, frothy, copious, mucopurulent, malodorous discharge. Card 123Q. What vaginal pH is associated with trichomoniasis? A. Greater than 5.0. Card 124Q. What cervical finding can occur with trichomoniasis? A. Strawberry spots or petechiae. Card 125Q. What is the treatment for trichomoniasis? A. Oral metronidazole or tinidazole. Card 126Q. Why must the sexual partner of a woman with trichomoniasis receive treatment? A. The partner may be asymptomatic but harbor the organism, leading to reinfection. Section 15. Hepatitis and HIV. Card 127Q. How is hepatitis A primarily transmitted? A. Through the fecal-oral route, including contaminated food, water, or person-to-person contact. Card 128Q. Does hepatitis A usually cause chronic liver disease? A. No. It is generally self-limited and does not result in chronic infection. Card 129Q. What test confirms acute hepatitis A? A. Detection of IgM antibody. Card 130Q. Why is hepatitis B particularly important during pregnancy? A. HBV can be transmitted to the fetus or neonate and can cause significant neonatal infection. Card 131Q. Which hepatitis B test is used to screen for active infection? A. Hepatitis B surface antigen, HBs AG. Card 132Q. What should be given to a pregnant woman with definite exposure to hepatitis B? A. HBIG and the hepatitis B vaccine series, according to the chapter. Card 133Q. Is there a vaccine for hepatitis C? A. N.